Good morning. I would like to, at the outset, thank you, Dr. Bindu Kuti and team for inviting me every year to be a part of this wonderful meeting. Greetings from Jain Institute of Pulmonary and Sleep Medicine. Today, what I'm going to do in the next 30, 40 minutes is take you through the, am I audible? Hello? Hello?
Yes.
Am I audible?
Yes, sir. You're audible.
Okay. So next 20, 30, 40 minutes, I'll take you through our journey of setting up a lab and how we are doing the work with reference to obstructive sleep apnea. So we are going to talk about our experience over the past decade. So what you see here is the earliest description of the so-called sleep apnea. In fact, it is not sleep apnea. It's a combination of sleep apnea with obesity hypoventilation. So this is a famous paper published by Charles Dickens. So Joe, this is a fat boy who was working in a restaurant, serving food and beverages. And in between, he would fall asleep. So till 80s and 90s, and even our textbook, when we graduated, we would say obesity, hypoventilation syndrome, or Pickwickian syndrome. OSA was not recognized, but this boy had all the features of right heart failure, carpal tunnel. In addition, he was also snoring and sleeping. So it's a combination of obesity and hypoventilation, OSA and obstructive sleep apnea and hypoventilation syndrome. So the first sleep lab we established, I attended a workshop in 1998 at Delhi. So at that time, I was sort of, it was all Greek and Latin to me, epoch, montage, all those things. So we attended a workshop. Then I thought we should do something new. And we were actually reading in our textbook about sleep apnea, Crofton textbook of respiratory medicine. There's only a small half a page note on the sleep apnea. That was back in '83. So what we set it up, and it was such a made a big news. The Kargil was going on. And we set up, and this reporter thought it was worth reporting. It came on the first page. So that was the novel and very new in probably South India, probably second full-fledged sleep lab dedicated to clinical use was set up in Mahavir Jain Hospital in 1999. So that was our first journey. And we didn't have any expertise, how to set it up, how to go about it. So I went to Australia, spent some time with Professor Sullivan, who invented the Cpap, acquired some knowledge and came back, and we learned and we set up. And initially we set up this in Jain Hospital. So then the story started. So we didn't know how to actually fix these electrodes, which should stay for 8 hours. It's okay for a EEG, you do it for half an hour. But the challenge was to get these electrodes placed on the head during the sleep. When the patient moves around, the electrode should not come out. So we were using colloidine at that time. That was what the company recommended. Later on, we found that 1020 gel actually keeps the electrodes in place through the sleep. So that's how we learned, and it was a sort of a worth learning experience. This story is a middle-aged bus driver drives the vehicle over the footpath, injuring pedestrians. An executive drives into a tree, escapes with minor injuries. Then wife of a bank refuses to share the bedroom with her husband. Passenger asked to leave the compartment of the train by co-passenger. So these are all live stories from our patients. So all of them suffer from one problem, that is obstructive sleep apnea. The two dominant symptoms are, the last two here is because they were snoring. Here they fell asleep during the day and got into the accident. So predominant symptoms are mainly snoring and sleep apnea. There's an article actually I captured recently. This was published somewhere 1 or 2 years back in the Indian Express. Train passengers force snoring travelers to stay sleepless. What these passengers in a third 3-tier AC compartment, this patient was snoring so badly, the other passengers took turns to keep him awake so that other passengers could sleep. So such stories, I thought it was very funny earlier, but actually in the real life, we see such cases, wife sleeping in the next room or in the other room, somebody is divorced. And this is what, in fact, there's a Western book, a Joe Harden, a gun fighter, actually shot dead his partner because he was very snoring. So this is the story of snoring and sleepiness and sleep apnea. So now what is the burden of the disease? So this was a small abstract published in by ResMed in 2000, American Thoracic Society. We have 1 billion people worldwide have sleep apnea. That's a huge, huge number. So in India, we thought it was a novelty in way back in 90s. That's for 20 years, 22 years back. But I think in India also, it's equally, we have common disorders. So it affects approximately 2 to 4% of the population who have symptoms and polysomnographic evidence of sleep apnea, and another 20% may have mild sleep apnea, which is not reported. So it's a huge cost to economic burden. 1 billion people worldwide have sleep apnea. This was 18, so probably numbers are increasing across the globe, including India. So now if you look at the number of papers, that's what when I graduated, I was in 83, there are only some 1920 papers published in 1980. And now you look at 2018, we have more than 1,500 papers published dedicated to sleep apneas, either physiology, clinical, whatever it is. So there's huge surge of more than 150% of the number of papers published every year is increasing phenomenally because it impacts every walk of life, plus also all other comorbidities. So what is the prevalence? As I said, in India, it is equally common. I picked up some few articles which are published. This is actually a population based in the sense they screen all the patients who were applying for driving license in 542 male driving license applicants. So what they found in this application screening question, 23% was found in those who are applying for driving license, because that is one of the areas where it impacts driving. Sleep apnea and driving doesn't go well, because those who have sleep apnea are more likely to get into accidents. So similarly, they looked at the PhD data. This was published in one of the dental journals. 120 underwent PhD, 57 had OSA and high CRP levels. So almost 47 of their patients. So these are many more papers are like that. It's just a sample I showing you that sleep apnea is a fairly common problem in India as well. So now if you look at the sleep disorder breathing, I think Uma has already spoken to you about this. It is characterized into 4 groups. The first group which I'm going to talk is obstructive sleep apnea hypopnea syndrome. The second group is central sleep apnea hypopnea syndrome. The third group, cane stroke, respiration, and obesity hypoventilation syndrome, all come under the category of sleep disorder breathing. Earlier, we were just calling OSA, but this is the subclasses of sleep disorder breathing because it happens only during the sleep. So another is the upper airway resistance syndrome. It's more like a research. We don't clinically we can recognize, but basically we are looking at the tip of the iceberg, where I assume there are 3 to 4 crore people with sleep apnea in India, and the most severe forms we are diagnosed and treating. We have not even touched the mildest form of the disease. So what is obstructive sleep apnea? There are 3 characteristic features. One, it is characterized by repetitive episodes of upper airway obstruction. That means during the sleep, the upper airway closes. It is associated with a reduction in blood oxygen saturation terminated by arousal. What's happening is there is upper airway obstruction. There is a drop in the oxygen saturation terminated by arousal. So why do they have this? So if all of you know that nobody snores when they're awake, the snoring starts only when the patient goes to sleep or with the sleep onset. So that is because the neuromuscular tone drops and the airway becomes flaccid. As we are breathing in and out, the airway gets into vibration. That's how you get snoring noise. And when the neuromuscular tone goes further down, it has a tendency to collapse. So once it is collapsed, though there is an effort to breathe, but no air is flowing into the lung, either partially or totally, causing desaturation. So this defines obstructive sleep apnea. So what are the consequences of this? 3 things. 1, repetitive airway obstruction. Number 2, hypoxemia. Number 3 is arousal. So this directly reflects in the daytime function. So once there is a repetitive asphyxia or hypoxemia, you get hypoxemia, retention of CO2, hypercapnia, acidosis, cardiac dysarrhythmias, blood pressure, pulmonary hypertension, and hypertension in older patients. These are all the consequences of hypoxemia. with the massive sympathetic discharge it causes each time the upper airway closes is the consequence. So now as I said earlier, there is a frequent arousal. So by definition, each apnea should or hypopnea should be more than 10 seconds. So what it causes a repeated arousal in a day, in the night. So sometimes like the patient may in fact have an upper airway obstruction to the tune of 100 times an hour, almost every second. We've seen very severe sleep apnea. So that actually it is like as though the patient is sleeping 7 to 8 hours. The sleep architecture is distorted and the patient feels very sleepy during the day. So that is the characteristic feature of this sleep apnea. One is snoring. Next is excessive daytime sleeping. That's how they come to us. So this was actually 2003 data, which was on the website of the European Respiratory Society. So the most common symptom is excessive somnolence, daytime somnolence with or without fatigue. So this excessive daytime somnolence due to the upper airway obstruction repetitively during the night while sleeping impairs the quality of life during the day or when the patient is awake. So it causes driving impairment, then intellectual impairment, personality changes, mood disturbances, reduced libido, marital disharmony, reduce the whole of the function of the person or the patient is disrupted during the day, and which can create a lot of problems for the family life as well. So if you look at our own data, we have collected probably now across about 10,000 patients over the past 2 decades. We have about 5 labs in 2 different hospitals. So we do about 20 to 30 studies a month. So 92% of our patients had snoring. Daytime sleepiness as assessed by upper sleepiness scale 82%. Choking or apneic spells 66%, unrefreshing sleep. So this defines sleep apnea. So patient is snoring, feels daytime sleepiness, has choking episode. And another common symptom is the patient feels unrefreshing and sleep with tiredness and waking. When somebody sleeps for 7 hours, they should get up crackling fresh. But if you feel you want to sleep for some more time, that means your sleep is inadequate, either in terms of the quality or the quantum of hours you need. So snoring, daytime sleepiness, choking spells, unrefreshing sleep, tiredness and waking are the most common causes in our own group of patients, which actually correlates well with the world data. And of course, patients may also have some morning headache, loss of libido, mood and personality changes are also noted in this group of patients. So now one thing is, as I said, the excess sleepiness can give rise to daytime road traffic accident. Why? Because they didn't sleep well. We are talking about not the nighttime driving. We are talking about patients who get into the road traffic accidents while navigating a vehicle. So what this Young et al. Published in NEJM, they found out that the odds ratio of developing, that means if somebody has a sleep apnea, is more likely to have at least one incident involved in a road traffic accident. Our own data showed that almost 8% of our patients had near misses. This included our KSRTC BTS buses, those who drive cars. Some of them actually have met with a lot of injuries, fractures, quadriplegia, etc. So compared to a drunken driving versus the sleepiness driving due to OSA, in a drunken driving, the patient is drowsy, feels sleepy or drowsy, but when he is confronted, he takes evasive defensive actions like braking or steering the vehicle. But in sleep apnea, what happens? He just shuts off from the world. That is, he falls asleep. Then you can't apply the brakes. So the head-on collisions and fatal accidents are much more common in OSA patients compared to drunken driving accidents. So now if you look at the next is not only this, we have also seen patients who are asleep at home getting into accidents. 4 cases we have not reported, but 2, these are the patients who fell down from their bed. One had actually it was referred by a neurosurgeon because the patient had a subdural hematoma, burr hole, and they found out he was snoring. That's how they referred to us. So we had 2 with head injuries needing intervention. 1 case of shoulder dislocation, they fell down from the bed, and one case of fracture of the arm. So these are not driving. We are all patients are asleep. They fell out of their bed because of the apneic episode. And in fact, you can also have a bedroom injuries due to sleep apnea. So the predominant brunt of this is felt on the cardiovascular disease. What happens is the patient with OSA, because of repetitive upper airway obstruction, hypoxemia, acidosis, and each time there is an obstruction, There is a massive sympathetic discharge, which increases the afterload on the heart, and the catecholamines are released. So they can give rise to hypertension, ischemic heart disease, cerebrovascular disease. It is that the cause or the association is very strong. The precise mechanisms are unclear, but multifactorial. So this is another longitudinal study, relationship of sleep apnea to the blood pressure in general population. One is a sleep heart study, then which was published in JAMA. Another is Wisconsin sleep cohort study. What they looked at odds ratio, if somebody has an apnea hypopnea index, as it becomes more and more, they get into the range of severe. The ratio of developing blood pressure is more than 1.5 and about almost 3% here. That means somebody who didn't have blood pressure to begin with develops sleep apnea. So subsequently, this sleep apnea will act as a risk factor for the further development of blood pressure. So it is strongly associated not only with the pathogenesis and pathophysiology of blood pressure, but also the patients who are on multiple medication will also benefit from treatment of hypertension, because you can bring down their number of medication they are consuming for the blood pressure. So this is another slide which shows that 40 to 50% of the 45% have hypertension, coronary heart disease, heart failure, stroke. What you see in the bottommost is the refractory hypertension who need 2 or more antihypertensive medication to bring down their blood pressure. These are the groups, somebody who is using 2-3 antihypertensive. In fact, you should actually look for whether this patient has sleep apnea or not. If you look at the obesity and the obstructive sleep apnea, okay, what's happening here? There, one is obesity as a obesity in terms of BMI and visceral obesity, both are risk for one, diabetes, blood pressure, stroke, etc. Now, if you look at diabetes, we are the diabetic capital of the world. So diabetes is very common. What's happening in the red bar here represents a non-obese, non-OSA patient. Yellow represents the obese patient. Green is the sleep apnea patient. So the risk of this increases when both are clubbed. So if you look, OSA alone has a higher risk for the patient develop diabetes compared to obesity alone. A combination will definitely increase. A combination of obesity and sleep apnea will increase the risk by almost 30-40% for development of diabetes. Similarly, the odds ratio also increases. Relative risk increases from 3.6 with a combination of 11.8. What it means is, if somebody has obesity, also has OSA, he is more likely to develop hypertension, 5 to 10 times more common than without these two comorbidities. So our own group of data, our own patients of 8,000 and odd, what we found out 44% of our patients had blood pressure. They also have surprisingly a overlap syndrome. That means they had underlying asthma and COPD 18%, diabetes about 16%. So in the world, we have seen that 15 to 20% of the patients with OSA also have diabetes as a comorbidity, hypothyroidism, road traffic accident, MI and ischemic heart is about 8%. Some 4% in fact had a renal failure as well. Cerebrovascular accident is 1.8%. So actually I'm surprised because now we are picking up the neurology group. If you look at the world literature, it's a very common problem, stroke, etc. across the globe, but we don't have enough Indian data. I think Bindu Kuti should help us to get more data on patient with stroke. Those who have transient ischemic attack probably have a higher number of patients than what we are showing here, because ours is a pulmonary unit. So if you look from the neurology unit, probably you'll pick up more and more patients, because since, as I said, sleep apnea impacts both the complete cardiovascular system, coronary arteries, cerebrovascular arteries, all of them are impacted. So if I go to the next slide. So this is what we have, some of the postgraduate studies. I'm just showing you that the patient of OSA, that sleep apnea and obstructive airway disease, we had about almost 52 had restrictive and another 12%. Mean age was 51. So it's a disease of the basically elderly. Similarly, what's happening is, out of this, what are the other risk and comorbidities we've seen is patients have retrognathia 6%, diabetes 34%, blood pressure 52%, ischemic heart disease 13%, and 11% of hypothyroids. So now we also looked at this another thesis paper. What we looked at is heart failure and sleep disorder breathing. Out of 40 patients, we screened for sleep apnea patient with heart failure. 33 patients were found to have sleep disorder breathing. Out of that, 29 patients are obstructive sleep apnea. So what it means is heart failure also is a sort of where there is a lot of disturbance in the sleep, both the cane stroke breathing as well as obstructive sleep apnea. Unless you treat, their heart failure will be difficult to get under control. So this is what the sleep disorder breathing at a higher resting heart rate, lower resting oxygen than the no sleep disorder breathing group, though the numbers are small. Both the systolic and diastolic pressures were high. Their ejection fraction was also higher. That's what we're going to show in the next slide. So what you see is resting SpO2 in the sleep disorder group was lower compared to the no sleep disorder breathing, no OSA. Excessive sleepiness is also more compared to the non-OSA patient. The ejection fraction and average were lower than compared to others. So that means it is impacting the whole functioning of the heart if the patient has a sleep disorder breathing. So the next common problem now, the population prevalence of OHS is unknown. We know the more the obesity has taken an epidemic proportion, especially with our COVID times. People are putting more and more weight, so it's become actually epidemic. So it's increasing. It's likely to increase in the further with the people not moving, staying home, no physical activity, eating more. So you're going to have an epidemic of obesity. Studies have shown 10 to 20% of the obstructive sleep apnea also have obesity hypoventilation. A meta-analysis showed that 19% had hypercapnia. And what I'm trying to tell is the OHS and OSA are two distinct entities. Obesity hypoventilation refers to because sheer obesity, patient does not adequately ventilate during the night, ending up with the elevated carbon dioxide. Whereas obstructive sleep apnea is a repetitive upper air obstruction causing hypoxemia and arousal. So both are distinct. So, but most commonly, most of the OHS patients also have OSA. It works in combination. So when you say that a patient was more than BMI of 30, he should have an awake carbon dioxide of more than 45, and other alternate cause of hypercapnia like COPD and all, hyperventilation has been ruled out. So what is surprising is that whereas the sleep apnea is a disease of predominantly male, OSA is predominantly male and females are less, whereas OHS, OSA, it is equal proportion. So it can affect both the males and females. So this was one of the papers actually published in Karnataka. I think Dr. Guru Prasad, I've also worked in Colombia. He published this paper, Seizure Disorder and Obstructive Sleep Apnea. 40 cases were taken. He was contemplating it is actually you can either have a breakthrough seizures who are well controlled due to sleep apnea, which can act as a sleeper. One, quality of the sleep and the desaturation can trigger, or isolated sleep apnea itself can cause isolated nocturnal seizure. So this was published in Shimoga, I mean, one of the local conferences. So clinically, I think Dr. Uma must have taken you through this. Anyway, I will briefly take you through this. So most of them are obese. They are males with a short neck, narrow oropharynx, have micrognathia, retrognathia, and they may be associated disorder like hypertension, ischemic heart disease, pulmonary hypertension, cardiovascular accident, and hypothyroid. So this is what so this is a typical patient who can see his profile. He has got a retrognathia, small chin retrognathia, short neck with lot of fat. So this is a typical patient with what you call craniofacial abnormality of the structure. So sleep apnea does not basically governed by two things. One, the neuromuscular tone, how it is maintained during the night, especially the upper airway dilator muscles. Number two, how we are born with our structure. So structure of the neck, the mandible, the maxilla, all will determine a combination of the structure and physiologically how the tone is maintained. Will some patient may develop sleep apnea, others may not. So typically this is what you see, BMI more than 28 to 30, neck circumferences 40 are increasing, waist, so all of them indicate obesity. They may have hypertension. Orally you can find uvula edematous, congested uvula, narrow oropharynx. Most of them have Mallampati score of 2 or 3 or 4. So our own age group, we had a predominantly 40 to plus or 50. Also, we had a small group who were not obese. So male to female. So it's a predominantly disease of the males, like in the Western world, 3-1 OSA. Whereas OHS, it's equally distributed. Most of our patients are obese. 83% of our patients had a BMI of more than 28. And most of them are sleepy. 70% of our patients had a daytime sleepiness as well. So thus to diagnose, you need a high index of suspicion, snoring, daytime sleepiness, choking, apneic episode, unrest sleep, tiredness on waking up. So we also looked at some data. Is it possible, apart from this questionnaire like Stop Bank, Berlin questionnaire, we also can just measure the neck circumferences, add measure the circumferences, add 4 to the hypertension. If the patient is choking, add 3. Sorry. And a total score of less than 43 low probability, 43 to 48 intermediate, and for more than 48. But what we did was actually when we took the neck circumferences, if the patient had blood pressure, added 4, had a choking episode, added 3, but actually our numbers who were polysomnography confirmed was coming to 40. So basically, from the anthropology point of view, our neck circumference may be lower than in the Western literature. So we may need to redefine the neck circumference as a risk. So probably if you look at 40 as a number, it will all be okay for our Indian population. We need to validate this data. So that means we have a lower neck circumference. So this 43 low probability will actually will make in our own group as an intermediate probability. So how do you diagnose OSA? All-night polysomnography. The two main, sorry. So the diagnosis OSA, all-night polysomnography. Two main polysomnography tests performed in the sleep lab are all-night polysomnograph, daytime multiple sleep latency. I think because of we don't do routinely. In fact, some of the patients were sent to NIMANS for the sleep lab because it's labor intensive. You need time. You need a well-trained technician to interpret that. So, but we substitute that with the Epworth sleepiness scale as a standard. So what is the waiting period? It's huge. This is some year back, 2004, probably still, because if you are looking at 2 to 1 billion population waiting list somewhere from 7 months to 36 months in Canada. So in India also, we have a waiting period of about 2 weeks. So PSD, probably all of you have gone through, I don't have to go through. So you have basically as a pulmonologist, I look at 2 sort of sets. One is your neuro channel, which will tell me the sleep stage, arousal. Another is a respiratory channel, which you are interested, which is picked up by a chest and abdominal bands or piezoelectrode. And we also look at the airflow at the nose and the mouth. And other recording includes snoring, ECG, pulse oximeter, body position, leg EMG, etc. So this actually I'm going to share you is one of our first patient. This patient, that was I think 2001 or 2000, I think so. What happened was this fellow was a water meter reading. Earlier, they used to have this water meter. This water meter will come with a book because most of the water meters which supply water, drinking water to the home is fixed on the floor usually normally. So he would come take the reading, take down and reading. And what his main complaint while taking that reading, he would fall asleep. So that's what he came to us. So that's the first pickup on maybe first or second case. So I said, okay, why don't you come? We'll do the sleep lab for you. So by that time we had done some testing and standardized our procedure. We are using colloidin at the time. We got him into the lab. What you can see here is now each is epoch is a 30 second, 30 second, 30. That means there's already 90 plus this is another 15. So 120 seconds. So what you are, this is only respiratory channel I'm showing. What you see in a sleep apnea, what are we looking respiratory? One, there is a air, there should be airflow at the nose and the mouth, and there should be a respiratory movement. If there is no flow, that means air is not getting in or out, either due to central sleep apnea or obstructive sleep apnea. What you see here is 120 seconds, no airflow into the lung. You can look at the saturation has almost gone to 54. If somebody has a ischemic heart disease, he will actually may die, in fact, in the sleep because of a massive heart attack, pulmonary edema. And this causes a massive sympathetic discharge, which can push up your blood pressure to almost 200, 300 systolic. You can have a stroke, so many things. Now, what you see here is a continued effort of both the thorax and abdomen. The upper area is closed, but the patient is continued to make an effort to breathe. And finally, it has actually snoring has started. He re-established this airflow. So that's how you find the snoring there. So there is no snoring because the upper airway was, no air was moving in and out of the airway. So only the movement of the air causing the vibration of the soft tissues will give rise to the so-called snoring noise. So this is a classic case. In fact, we were scared this patient may die on us. Then we had to put him on CPAP. He got better. So similarly, during my sojourn with the sleep, in fact, we were scared. We would sometimes wake up the patient because saturation would go to 50, 40 like that. We were afraid that patient can arrest on us. But then when we developed the expertise, they would have been like that for some time. They would have got used to it. So now this is another classic case of, again, obstructive sleep apnea. What you can see, this is the no airflow. That means movement of no airflow at the nose and mouth. And there's a continued effort. And snoring again, he opened his airway, he started snoring, again apnea. So frequently apnea is going on. Now the third one, the next slide, what I'm going to show is what happens in a patient who is obstructed. So if you can, these are all the thoracic band, this abdominal band, which picks up severe thoracic and abdominal movement. This is the, airflow. So if you really carefully see from left to right, this is the thoracic band. If you look at the cursor, it is going up and down. And similarly, abdominal movement is also going up and down, followed airflow. Now he developed an apneic episode here. What has happened is, now you see, now what's happening, thoracic movement is like this, abdominal movement is reversed. This is called, we call as paradoxical breathing. What happens when a patient obstructs the upper airway? There is a tremendous, but there is a continued neuronal output for you to breathe. So the chest keeps on expanding and contracting with the upper airway closed. So it is like applying a vacuum. That means you develop a tremendous, massive increase in the negative intrathoracic pressure. So what happens, normal breathing, your diaphragm should move down. But in sleep apnea, which is paradoxical, in fact, the diaphragm, instead of going down, is sucked into the chest. So that's how you get a paradoxical breathing, which actually represent a very high negative intrathoracic pressure. The same negative intrathoracic pressure is also putting a lot of pressure on the heart, because the heart will have to overcome and contract against this negative pressure. So it increases the afterload. So this episode of low oxygen, continued effort, increasing afterload, and what happens, your sympathetic nervous system discharges massive amount of catecholamines, which raises your BP tremendously. There's a huge surge of the blood pressure, huge release of catecholamines, ends up with a massive, so again, when the airway opens, the blood pressure suddenly drops. That's where you find on the EMG channel, there is an arousal. So it terminates with the arousal. So this kind of sequence is episodic apnea, hypopnea, and arousal happens to the tune of sometimes in severe patient more than 100 times. It may start with 5 up to 100. So most of the cases we see is severe, which have more than 30 times an hour of apnea and hypopnea. So next slide, what you see is a typical, it's like a cardiac arrest, it's a respiratory arrest. This is called central apnea. What's happening is there is no movement of air, but the airway is open. There is no movement of the thorax, no movement of the abdomen. So that means it's equivalent to your cardiac arrest. The patient stopped breathing, respiratory arrest. So it keeps till the patient reestablishes his air movement of the chest. So this is typically defined. In central apnea, upper airway is open. There is no airflow at the nose and the mouth, as well as there is no respiratory movement. Whereas in obstructive sleep apnea, the movement of the thoracic and abdomen is there, but the upper airway is closed. So one with the open airway, another with the closed airway. So this is a typically we do sometimes to sleep apnea. We do what's called split night study. It's very useful for us because we can convince the patient. What you see on the left half is the diagnostic study. This is the lower red one is the apnea. The upper one is hypopnea. And you can see the snoring here. What we have done is we have put the patient on an auto CPAP. What you can see, this pressure actually opens the airway and keeps the airway open. So the snoring has disappeared. Desaturations have disappeared, apnea, hypopnea, everything has disappeared, and the patient has developed a rebound REM. So most of the patients with sleep apnea will lose out on the REM sleep. This is what we re-establish, and that's where actually you need both REM and non-REM for a good quality daytime function. This is called split night study. So our own patients, 52%, as I said, had severe sleep apnea of more than RDR, AHF more than 30, 16 to 30 had 13%. And another small group had a milder is 35. So, but most of them or majority are moderate to severe sleep apnea. So then portable, again, we have a lot of people who are offering distributed driven, no proper assessment, improper reporting, multiple specialists trying to eat the cake. So what's happening is that disrupted the market. So no reporting, patients get prescribed unnecessary, unwanted medications, treatment. So this is what this patient had came to me for third opinion. You can see he has undergone a surgical procedure that chopped off his uvula to open up the area, but he continued to have. So once you do this, our CPAP treatment will become less effective. Using a nasal mask, we have to resort to full face mask. So these are all the treatment approaches. Tracheostomy, which is not acceptable. That's how they started with. Increase the nasal pressure, overcome the upper airway collapse by creating a pressure at the back of the throat. Then structural weight loss, body position, UPP, that is uvulopalatopharyngoplasty, hyoid and mandibular repositioning, adenotonsillar resection. I'm not going to. So what you essentially do is you have to make the airway open by various means so that the patient have a continued airflow into the lung. So this is what the various UVPP, UPPP, LA, UP, laser guided, lingual, all multiple, but it's not the gold standard is the CPAP. Only when they don't do well, we consider this. So nasal continuous positive air pressure is the gold standard treatment for OSA. So used first time in 1981, acts by providing a physical pressure. CPAP system consists of blower unit. I'll show you that. Actually, Professor Colin Saline from University, that's where I went and spent some time with him. He is a wonderful researcher in the sense, it has impacted billions. I think you should be given a Nobel Prize for, he reversed a vacuum cleaner to give this airway splinting, a huge. From the vacuum cleaner size, a big one, the machines have become very compact as of now. So it made a huge difference in millions and billions of people. So this is how a CPAP works. So what you have is, the upper airway closed when the extraluminal upper pharynx, larynx, airway pressure is more, it tends to collapse. Whereas in if you reduce this pressure by loss of weight, etc., it can open the airway. But there's what we do is we can't do this frequently. What we do is we apply a pressure through the nose. That is where this CPAP fits. And this overcomes this extraluminal positive pressure by creating a positive pressure. So we call it as a continuous positive airway pressure is because both during the inspiration and the expiration, the airway is always positive with reference to this pressure so that the air can flow easily. That's how a CPAP looks. This is how a mask is, that's how it is fitted. But when the patient goes home, none of these EEG wires and all will not be there. They just take it's a small mask and a blower connected to blower through this hose. This is our sleep lab. So we started from a small lab with one bed. Now we have a 3-bedded unit in our row. This is how we, actually you can see there's no windows here. One of the good quality sleep flat should have no windows, no light, because you need to provide an environment which is totally soundproof and dark to induce sleep and maintain sleep. So, but of course, our sleep apnea patients are slow, sleepy. When we are talking to the patient, if you don't talk to them for a minute, they fall asleep. That is a different story, but ideal sleep lab should have no sort of light or sound coming in. They should have all the excess oxygen, emergency medicine to treat. So in summary, sleep apnea burden is huge. Awareness in general is very low. Underdiagnosis is very common. Therapies are emerging based on the pathophysiology or the what you call personal medicine, gain loop theory. Then there are all pharyngeal, glossopharyngeal stimulation. Various things are there. Probably that will be another topic. CPAP though is very used. One is a cost and acceptability. I'd like to complete this talk by thanking you, the Bindukutti team, for involving me in this every year sort of event. Thank you. And
thank you, sir, for that interesting talk. We will take up some questions. You can open the chat box and see the questions.
There are 8 already sitting there. Okay.
Yes.
Reference kindly. Are people with deviated nasal septum also vulnerable to OSA because of breathing difficulty? Common to both. That's one question. Yeah, basically what happens is a deviated septum will cause some kind of a negative pressure because of the deviated septum. it becomes difficult. Yes, if there's a very gross deviated septum. So deviated septum per se will not cause sleep apnea. If the patient, see, as I said, the sleep apnea, what you need to understand is governed by two things. How we are born with, your structure within the neck, oropharynx, that is one. Number two is how our brain controls our neuromuscular tone in different stages of sleep. So the neuromuscular tone and the oropharynx will keep you either open airway or closed airway. So the only the neuromuscular tone decrease they won't cause. There should be a combination of structure and the physiology is the result where. So if the patient has a deviated septum, if the patient has a sleep apnea, it will worsen it actually because of it will create the various pressure points in the upper airway and upper airway. Number two, when we apply the Cpap, it's a gross septum, we cannot push the air through. So it becomes difficult to acceptance below. So then we may need to get that deviated septum fixed.
Only one question. I think only one question. Yes, there is one more. People with respiratory disorders like asthma.
This is what people with respiratory disorder like asthma, allergy, rhinitis, COPD are also prone. This is what I showed you. About 18 to 25% of our patients have these comorbidities. See, most of these chronic disorders, the diabetes, hypertension, they are all linked to each other. In the modern era, it is an interdependent risk factor. So when I treat a patient with sleep apnea, see, if you are obese, you say you have to lose weight. Then we will say if your BP, you have to bring them. Why should we? It's because blood pressure per se will not cause any symptom, but still we want to get it down. Sugar will not cause symptom. We need to control it because of the complication that can come in, like heart attack, strokes, etc., etc. Similarly, OSA is a very, very big factor. One, per se, it can give rise to these complications. Number two, it can modify the other comorbidities like diabetes, obesity. So it acts synergistically. As doctors or clinicians, when we treat, we want to bring down all the risk factors. If somebody is smoking, we'll say stop smoking, reduce weight, control the sugar, treat sleep apnea. Then only you can get a normal physiology working. So asthma and allergy, yes, common, but if they have a sleep apnea, it's an independent problem we have to treat. In fact, we call this a overlap syndrome, COPD, 18 to 20%. So we treat asthma, we also treat sleep apnea. Somebody asked, what is obstructive sleep apnea?
Hypopnea.
I think it's like Rama and Lakshmana. Who is Rama and who is Sita? Or my talk went over the head. Okay. Treating OSA with Cpap can also help reduce obesity. But yes, definitely. In fact, studies have shown regular Cpap has a long-term benefit. It helps you to reduce function more effectively during the day. One, cognitive functions improve, memory improves. Then number three, blood pressure comes. Definitely, there's a lot of papers are there. When you start them, if the patients have 3 or 4 medications to control blood pressure, you can bring it down. Similarly, obesity also improves by reducing. By reducing the weight itself, sleep apnea gets better. So it's an interlinked problem through the leptin mechanism. Will you tell about acceptance of public, especially in India, sleep medicine? How well? See, awareness is a big challenge. I think I must have given more than 100 plus talks across India because, as I said, 99 it made into the next to the Kargil war. So nobody had heard of sleep apnea till 21. So probably our lab was second. Madam Binukudi might have had a neurophysiology, but as a clinician offering, diagnosing and treating sleep apnea, probably ours was the second lab in India. Okay, so rare because it's labor intensive, you need space. So most of the government sector, they should do. If they don't in the private sector, it's also the costing, how they can recover the cost. That's another issue. So this always is issue that public only when, but they are thankful. A lot of patients are thankful because it has made a huge difference in their lifestyle. Using Cpap actually makes a wonderful, especially they fall asleep, their daytime sleepiness, it makes a huge, huge difference. Any life, okay, how to take care of OSA at an early stage, at a young age. So basically, it's not a disease of young age, but though, of course, pediatricians are also looking at this. Tonsillectomy is one option where actually upper airway is good, so they get better younger age. But most often we see is 40 plus patients in this age group is what we see. So you have to appropriately treat all the comorbidities and treat them. The other is early means awareness you have to increase. That means both among the public and among the medical fraternity awareness should become, because as I said, it's affecting 2 to 4% of our population, as common as diabetes and blood pressure. We have to treat. Cost of CPAP, it is 40 to 50,000 is what we use automated machines. Yoga and medication, madam, you have to add yoga. In fact, medication, there's no medicine, but I was doing a review of literature. This gain loop theory, which is actually phenotyping, if Dr. Bindu could agree, we should do a study on phenotyping the sleep apnea patient. There are 4 distinct entities where some have got called position POSA, that is position dependent sleep apnea, where typically only in supine it happens, you turn them with some kind of a neurological device which will stimulate them. That is one phenotype. Another phenotype is the structural one. The third one is the gain loop theory, which is physiological, where they've tried acetazolamide to reset your gain loop theory. So there are a lot of phenotypes emerging in sleep apnea all. So finally, you have to keep the arrow, that is CPAP is standard, but we can also modify some of the lifestyle. There is also called as hypoglossal nerve stimulation, which can help the patient to open up when there is an apnea, it will like a pacemaker, it stimulates, it opens the airway.
I think we have come to an end of.
Yeah, I think 11 o'clock done.
Yeah. And nice questions also.
Yeah, so somewhere are there anyway, probably we should have some other time.
Yeah. Thank you, sir. Thank you so much for the wonderful.
Thank you. Thank you, madam. So we wish we'll meet again physically next time.
Yeah, we have
Thank
got a
you.
very